So today I'm pleased to introduce Dr. Pete Stiles, Medical Director of Pain Management at TRIA Orthopedic Center, right across the road from here. And his opinions and views on the opioid epidemic, that's often called crisis. It is something that I became aware of recently. I suppose the Prince death kind of triggered my interest, so the last month or two I've sort of paid attention to the headlines in the media, and things like 1 in 3 patients on Medicare are on opiates. Didn't know that. Wall Street Journal about a month ago tracked some fentanyl production in China, got it into the Mexican drug cartel and into the United States, and the cost of producing that batch, I don't know the size, was $800, and the street value in the United States is $800,000. Had no idea about that kind of stuff. So let me read a little bio on Pete, and then you're on. By the way, he has really good genes. He is the son of Don and Leslie Stiles. So, Pete Stiles is the Medical Director of Pain Management Program at TRIA, where he practices full-time. Holding board certifications in both areas, he completed an anesthesiology residency and pain medicine fellowship at the University of Michigan, where he designed a nationally recognized web-based system to aid patients and primary care physicians in the management of perioperative pain. Locally, he serves on the boards of the Twin City Medical Society. He holds memberships with the American Society of Anesthesiology and the Spine Intervention Society. So let's welcome Dr. Pete Stiles.
All right, thank you very much for inviting me to come in today. The last time I was standing in front of this club giving a lecture was in 2004. I recognize some of you from then, so this is a very good club with a lot of retention, but I had just returned from a summer I spent at a hospital in Ethiopia, in Africa, and actually part of what I did over there was sponsored by this club. So now 12 years later and a lot of training, I'm back and happy to be here. So thank you for inviting me. I want to keep this really, really informal and casual. This is something I deal with every day. So raise hands, interrupt me. I want to talk about what you guys want to hear about. Also fully recognizing that there are a good portion of very intelligent people in this room. I'll go into some of the kind of scientific background of some of this stuff too. So as John very nicely mentioned, I'm the medical director of a pain management program at TRIA Orthopedic Center. And I'm going to talk today first for a little while about what has been termed the opioid epidemic or crisis, and that's kind of taking a look at national and Minnesota statistics of how this crisis is impacting lives and production and everything else. And then we'll shift gears and talk for the second part about what can maybe be done to do some things about that. And the specific population I'll focus on is that in chronic pain. So chronic pain patients are kind of the driver behind a lot of this opioid epidemic. That's how these medications get out in circulation. And then it leads to other problems like addiction and abuse. 2 quick disclosures. As doctors, we're supposed to tell what other things we're involved in. So I'm a scientific advisor for a group called Chronotherapeutics. It's a group out of California that's trying to create novel and safer drug delivery systems, so I consult for them. And I'm also an unpaid board member of something called the Steve Rumler Hope Foundation. This is something that this club has helped support, and they've asked me more recently to be on the board of that, so I sit on their board. This is the most expensive privately held yacht in the world. It's in production. It's over $1 billion, called the Streets of Monaco. And this is where I would all invite you to join me if I could solve this problem. Because this is a problem that would, if someone could solve the opioid crisis and chronic pain, this would be a drop in the bucket. I'll talk about the economic impact of this crisis in a little bit. Objectives, 2 things I want to make sure we do today. We'll kind of describe the scope of the epidemic, how this impacts expectations in patients, and also, on the flip side, how medical providers deal with those expectations. And then we'll discuss some of the current options, what we currently are okay at, and what we hope to get better at in the medical community on how to manage pain and addiction as relates to the opioid crisis. So this is why it matters to everyone, even if you don't know anyone who uses opioids or who is in pain. Over 100 million people in this country experience pain on a regular basis. It is the #1 presenting complaint to health professionals, and it costs between $500 and $700 billion a year. Now, that is not just medical costs, lost wages, and those kind of things. But if anyone could even solve a part of this, we would have a huge way to save money and productivity. When you hear about the opioid crisis or the opioid epidemic, you have to start thinking about how do we get here? And I want to start to paint a picture. So for many, many years, there was not a problem with overproduction and overuse of opioid painkillers in the United States. And in 1996, a very important decree came out from the American Pain Society, which obviously has a lot to do with how we manage pain in our country. And they pushed through the importance of treating pain as a vital sign. So before that, your vital signs are your heart rate, your blood pressure, your pulse ox. And they added pain. So all hospitals started recording pain as a vital sign over the late 90s. Obviously, this had a few impacts or effects. Everyone started focusing on pain. The patients started thinking about their pain constantly. Anytime a nurse or doctor came into the room, okay, what's your blood pressure? Is your pulse ox okay? And what's your pain today? What are you feeling this morning? So it kind of set this level of importance for how we're feeling pain. And that progressed on to all the governing bodies and the regulatory bodies saying that this had to be something that was tracked, putting a lot of emphasis on this, and eventually hospitals are paid on patient satisfaction, right, and how we manage patients' pain. So that's the underlying kind of foundation for what we see over the next 2 decades. And I'll show you some of that now. We're starting to see in the last few years some more things come out. You can't read the Wall Street Journal or listen to Minnesota Public Radio for too long without hearing about the opioid epidemic. I put up some lay press articles, but in the bottom left of the screen is a doctor named Russell Portnoy. This is the guy who coined the phrase, the fifth vital sign. Turns out while he did that, he was also making money from Purdue Pharma, which is the maker of OxyContin, Percocet. So you can imagine there's a little conflict of interest. There's some lawsuits ongoing about misrepresentation of safety of drugs, efficacy of drugs. But that's in part how we got to where we are. You remember in the mid-70s, we had a heroin epidemic, and in the kind of late 80s, early 90s, our country had a cocaine epidemic, and this prompted all sorts of stuff. I remember being a grade school student, Dare to Keep Kids Off Drugs. Huge amounts of resources were invested in trying to combat these epidemics. Look at this graph. This is the rate of unintentional drug overdose deaths per year. And I circled those 2 other epidemics. What happened in 1996? That's right. Right when this starts taking off, we told everyone, we need to focus on pain. We need to be really aggressive with pain management. There's no ceiling on the amount of opioids you can give. The World Health Organization supported this at the time, so that's how we got this meteoric rise in problems with overdose death. This is a chart that merits a little bit of explanation, but I think it represents, yes?
This exponential increase,
Yeah.
Does this reflect also a payback to the doctors in recommending this?
Not directly. I don't make any money for recommending these. I'll show you something that gets sent to my email in just a moment, though. And it's not a direct payback to the doctor. We don't make any extra money for doing this. Indirectly, patient satisfaction is tied to your income. Very closely, right? You get bonuses if you have higher patient satisfaction. If you don't have good patient satisfaction, you don't keep your job. And when you have a patient who's addicted to a medication, what's the only way to make them satisfied? Well, you either spend 5 minutes with them and refill their medications, or you spend an hour with them explaining the long-term effects, what we can do to get you off this, how we can get you psychiatric, emotional, social support. So you can make a lot more money as a doctor if you just dole out the medications, but there's no direct kickback. That's a really good question. This is a chart put out by the University of Wisconsin. On the x-axis, so the bottom is something called the Human Development Index. So that's a surrogate for how developed a country is. Things like GDP, infant mortality. And so each dot represents a different country. The United States is this blue country. The size of the dot is the population of, this is a complicated graph. Size of the dot is the population of the country. Color of the dot is geographic region. So blue is the Americas, green is Europe, and then yellow is Asia. On the y-axis is morphine equivalents per capita. So this is amount of morphine, and this is how we track relative potencies of different narcotics or opioids, right? Fentanyl, Percocet, Vicodin, all can be converted to a morphine equivalent. So that's how we can talk about everything in apples to apples. So the y-axis is how much a country is consuming. And this is going to change over time. So this is a snapshot of 1980. You can see basically worldwide, morphine equivalence consumption was very low and stable. 1985, not a whole lot of change. Even to 1990, you can see some of the more developed countries, so remember, this way is more developed, starting to probably treat pain a little bit more aggressively. When we get to 1995 to 2000, to 2005, 2010. The data stops at 2011 right now, but look at the United States. I can't even reach it. And our little satellite Canada are responsible for more than the entire rest of the world combined in terms of opioid distribution and consumption. So there's a disconnect there between what we're doing in this country and the rest of the world. We're not isolated or protected from this in Minnesota. So the bigger graph on this page is the opioid overdose deaths in Minnesota starting in 1999. 60 people died from unintentional opiate overdose. And in 2014, 319 people died. So over less than 2 decades, we've essentially quintupled or more the amount of folks overdosing. And if you look at some of the national statistics, this is kind of on par with that. Enough people die every day that is essentially a jumbo jetliner going down every single week. If a jumbo jetliner went down, we would hear about it, we'd talk about it for a month. This happens every single week in this country, we don't really talk about it. Opioid overdose has eclipsed motor vehicle accidents as the #1 cause of accidental death. This happened in 2009. So more people now die from medication overdose or illegal substance overdose than motor vehicle accidents. And you think about the amount of resources we as a society put into making cars safe and making sure laws are enforced around traffic accidents. So this is what I was alluding to. This came in my email 2 months ago. I mean, this is in the setting of where we know that this is a problem. I got a direct-to-physician advertising with a new opioid that's now 5 times stronger than previous opioids. I thought that was amazing. And this is all I do, so I feel like I have a pretty good understanding of it. But this is going to go to every primary care doc in the country, and I can't control what their education is, and we need to work on that. So what's the evidence behind this? I've shown you that a lot of people are dying. I've shown you that we have very high consumption. What's the relationship, or where does that come from? And this is an article that came out in the Journal of the American Medical Association a couple of years ago that tied opioid prescribing patterns or practice to actual overdose-related deaths. Without going into too much detail, the chart that matters is Table 2, and this is patients with chronic non-cancer pain diagnoses. So these are your chronic back pain, headaches, knee pain, all the different things where it's not terminal or you're not dying from this diagnosis. They took a look at the amount of opioid used, and there appears to be a very, very clear threshold where if someone is taking more than 100 oral morphine equivalents in a day, which, believe it or not, is not that hard to get to if you're in chronic pain, you're about 6 times more likely to die than if you weren't on that medication. All other things kind of being held steady. So this was the first hard evidence that showed that You prescribe someone something and you're increasing their risk of death just from that prescription. So that is what started, because we as physicians only move the chains if there's evidence behind it. So this started a lot of these talks. So this came out in 2011. Who's at risk for opioid overdose? Not everyone is at the same or equal risk. Typically, we see patients who have a person or family history of alcohol or drug-related behaviors are at higher risk for actually overdosing. History of physical or sexual abuse in the patient, usually as a much younger person, and then this develops into a substance problem later on. And then anyone with co-occurring psychiatric conditions. This includes very common things like depression or anxiety. So those are the folks who are at risk for opioid dependence or addiction. Who actually dies from an overdose? This is even more specific. It's more commonly men, although women are not immune to this. More commonly Caucasian in their 5th and 6th decade of life, at home and usually alone. So that's kind of the population that we're talking about a little bit. And I think Prince fits almost all of those except Caucasian. So we can talk about that a little bit too. Naloxone is another thing that's been in the news. And once I finish this, we'll kind of set the stage for what we can do about what I'm talking about. But naloxone is a medication. It's an FDA-approved medication for reversal of opioid overdose or opiate effects. So real briefly, opioids are the pain medications that you think of as the heavy-hitting pain medications. All the way from codeine and tramadol, which are kind of the weakest opioids, all the way up to fentanyl and heroin, which are some of the strongest. Believe it or not, fentanyl is much stronger than heroin. And then there's things like methadone as well. So this includes everything like Vicodin, Norco, hydrocodone, Percocet, oxycodone, OxyContin, morphine, MS-Contin. Basically, these are all words for variations on a very similar chemical. That chemical can block pain to a degree. It also has a respiratory depressant effect, which is where the overdose death and morbidity, mortality comes from. And there's a variety of other physiologically active things. Patients on opioids for a prolonged period of time have decreased mood, obviously, have decreased testosterone or estrogen levels. It can really wreak havoc on cortisol levels on the body. So there's a lot of kind of underplay in addition to the things we typically think about. Naloxone is a very short-acting drug that can be administered either intramuscular, IV, or in the nose that completely relieves all opioid in the body. It competes with the same receptor and blocks that receptor. So you can have someone who's overdosed, not breathing, give them this medication, they will wake up, they will start breathing. It also reverses the pain control as well. So that's something you have to be aware of too. The only other thing worth mentioning here is that it's very short acting, so it's not a perfect cure. If someone were a first responder were to show up, administer naloxone to a patient, they would need to get them to a hospital because the opioid is going to be longer acting than the reversal. So it's not a perfect fix, obviously. The state of Minnesota is well beyond many other states in distribution of naloxone, and this is largely in part to the Steve Rumler Hope Foundation putting forward education and something called Steve's Law, as well as some other legislation that makes it legal for first responders to have access and carry naloxone with them. There have been, since this legislation was done, at least 15 or 20 cases where they think the patient has been saved, life has been saved from first responders carrying naloxone. Now, I fully recognize the dangers of abuse, addiction, and overdose. I've kind of told you guys about that, but the reality is this is not even a very good pain medication. So this is where my interface is as a physician. This is a complicated slide to show you that this is a real entity, but there's something called opioid-induced hyperalgesia. So this is a concept that's pretty complicated on a biochemical level. We're just starting to understand this as a research community, but we see that after a couple weeks to a few months, patients who are on regular opioid painkillers will start having more pain rather than less pain. You'd think blocking that pain would be really good and it would get them back to function. Turns out the opposite is true. And the way I explain this to patients that many can understand is our bodies are really good at adapting to regular stimuli. So if you go for a run every day, you're going to get faster and you're going to get more efficient at using oxygen. If you lift weights every day, you're going to get a lot stronger. If you block your opioid receptor every day, your body will just make more. It will become more sensitive. The peripheral nerve endings will be sensitized. You will have higher concentrations of pain receptors in your spinal cord. So we've demonstrated this in rat animal models, and we're starting to realize this happens to patients. This is why dose goes up in addition to things like dependence and addiction. This is why pain control gets worse and worse, so they start seeking stronger medications, and it's a self-fulfilling prophecy. We know why this is happening, and we know that even after a few weeks or a month or two, it's not even going to be helpful for pain. So how has the United States responded? Don't read this. This is a busy slide that basically says 3 or 4 years ago, the White House said, this is a problem. Smart people get together and do something. Those smart people came together in the form of the Centers for Disease Control. And on the 15th of March of this year, they offered a statement educating providers on how to more responsibly and safely use these medications. It was primarily aimed at primary care providers, and it covers 3 things: when to initiate or continue opioids, how to select or use them responsibly, and then adverse or risk factors, and most importantly, how to discontinue opioids when appropriate. And this is what it looks like. These are just the recommendations. The entire document's 86 pages. I'm probably one of the only people who have read it, but it's very complicated. So these are the principles that I distilled out of it. This is what I use when I'm dealing with chronic pain patients, and these are the ways I try and keep them safe. So the most important thing when you're dealing with any patient who's in any kind of pain, chronic acute pain, and thinking about using pain medications is setting a realistic expectation for that patient. Whether it's around the time of surgery, whether it is a chronic pain condition, you have to say what we can do and what we can't do with our current resources. And there's usually a pretty big disconnect there, to be completely honest, because you hear advertisements for things like painless surgery. That's not a thing. I mean, you can't do surgery without some pain because you're operating on someone. And to promise that really kind of is a disservice. So setting expectations about what can be expected really helps kind of take the edge off that entire experience for the patient. I try and avoid long-acting medications for short-lived conditions. I try to explain that the goal of pain management is to facilitate function and recovery, rather than simply block pain, right? You can do that for a time, but we need to go somewhere with our plan. I recommend that they don't mix sedatives, so patients who are taking anti-anxiety medications and opioids are 4 times more likely to overdose than just on one of the 2 alone. Yes?
Well, and then, I saw this slide especially, in 1985, I was in a car accident. I was in the hospital for 7 weeks.
Sure.
I was on morphine, every 2 hours. And at the 3rd week, they stopped the morphine. The 3rd week, just turned it off. And they prescribed Tylenol 3 with codeine.
Yeah.
And it was like a placebo. But in 1985, they knew that if I was continued on that morphine regimen, that it was going to cause me a problem. What's happened in the last 35 years?
Very, very little, other than we promoted this as a medical community. And if I was caring for a patient, if I was caring for you, I wouldn't cut someone off immediately, because I'll show you in a second, there's some problems with that too. Not only withdrawal, but migration to other chemicals that can be in there. So I think we've gotten a little bit better at how to slowly change that, but we need to start making those changes sooner rather than just sending someone out with huge doses of Percocet, because it's going to keep your satisfaction score up. So I wish I could have planted that. Here's the segue. So we got better at this in about 2012, 2013 as a country. So opioid analgesic overdose deaths started to level off. This is great news, right? Oh, God, look at heroin deaths at the same time. So this is to your point. If you cut someone off immediately, and there's this cohort of people out there that exist, right? Millions of people are opioid dependent. A third of Medicare patients are taking some kind of opioid pain medication. These people are out there, and they're everywhere. They're on your street, you know them. If you cut them off, heroin is really cheap and really accessible. And this is what you're starting to see. So it's a complicated problem. There's a lot of barriers to a solution here. I'm going to speed up a little bit so I can make sure there's a little time for questions at the end. This is a decade-deep problem with no quick fix. Our society wants quick fixes, right? And that's what you expect when you go to the doctor. Give me a medication, I'm going to get better. My blood pressure's high, I'm going to take this medication, it's going to be fine. I want my food in less than 2 minutes. There's no good answer for pain or chronic pain in that regard. The closest thing is an opioid. You can feel better for a couple hours, a couple weeks, even a couple months, but where does that leave the patient? And this is what we were talking about earlier. The incentivization on doctors and healthcare systems is to maximize satisfaction, not to have long-term patient safety. Because once that patient goes home and overdoses, it's not really the problem of that healthcare system. But if they wrote a kind of survey that was really damning to the hospital, that would be the hospital's problem. So this is a systemic problem. Addiction is very powerful. There's not perfect pain relief options, and heroin. So what can we do about this? Now I'm talking about just the patients in chronic pain population, not addicts at large. This is the 0 out of 10 pain scale that you will see at some points. So the body's alarm system, how we feel pain, that's what pain is. Pain is the way our body tells us something is wrong, there's something going on. In acute pain, I liken this to a house with a security system, and an intruder is breaking in. If you break your ankle, if you poke yourself with a knife, that's acute pain. It's very easy to describe, it's right there, I understand it, it's going to get better, the burglar goes away, the cut heals, everything goes back to normal. In chronic pain patients, that doesn't happen. There's a problem with the alarm system itself, right? So no longer, even if you replace the shoulder, it still hurts after the shoulder's been replaced because now there's a problem with the actual alarm system of that patient. It's a very challenging thing to treat. It keeps my job very interesting, and it's in part why we have a problem with opioids, because this is a quick fix. To manage pain sustainably, it's a team sport. Now again, I'm talking about chronic pain. If you break an ankle or have a hip replacement, that's a different question. But this is patients who wake up every day with pain, and there's a lot of them. The legs of the stool are what hold up an effective, safe, sustainable management plan. So I usually talk about having some kind of MD or pain physician involved, a physical therapy or functional therapy team, a behavioral care team, this is psychology or some other folks, and then addiction medicine. The nails that can kind of prop this together are an integrative health team. And now I'm really going to blitz because I know I got about 5 minutes left. This is obviously what happens if you don't do this well or do it right. The concept of multimodal pharmacology is a little bit foreign when you're trying to manage a chronic condition. If you have diabetes, you want one medication that fixes your diabetes. You maximize or optimize the dose of that medication and you're fine. In pain management, what we try and do is treat pain at multiple sites along the course of that pain signal. So wherever the pain signal is coming from, there's some tissue involved, then there's a nerve between that tissue and the spinal cord, there's nerves in the spinal cord all the way up to the brain, and then there's how we interpret it at a central nervous system level. There's a whole variety of medications that do this, but the crux is you want lower doses of multiple types of medications to spread out your risk, decrease side effects among multiple classes, and improve efficacy. The second area or thing that can be done for pain management are interventions, right? Everyone's heard of a cortisone injection in the knee or in the spine, things like that. We got to recognize these for what they are. Interventions can be very helpful, but you have to realize that they're only to facilitate function and improvement. And this is actually how I make my living. I do these pain interventions every day, but I do it in a way, hopefully as part of a bigger plan, saying, okay, we're going to use this window of pain relief to rehabilitate your low back, to get you to lose some weight, to do all of these other things that will help you in the long term. There's 3 broad categories of pain interventions, and quickly, basically, stuff that decreases badness, stuff that increases goodness, or other stuff. Decreasing badness is your typical steroid injections or nerve ablations. Increasing good stuff is what the really rich professional athletes can do, like get stem cell therapy or prolotherapy, injecting things back into their knees so they heal quickly. And then the other stuff is kind of becoming more accepted, ways to electrically block pain signals or implant drug devices. Physical or functional therapy is the next leg of that stool, and there are three things. I can't promise much in medicine, but there are three things I can definitely promise. One is that a lack of activity or exercise will eventually make your pain worse. Two, it's going to get worse before it gets better. If you're in pain for any reason and you're going to work through it, you're going to strengthen yourself, you're going to have some bad days before you have many more good days. And three, physical therapy, functional therapy is not a place you go, it's not a thing you do, but it's a lifestyle switch. It's waking up every morning and thinking, I know I'm going to have knee pain today. What am I going to do active to improve on that each day? And a good program will be able to teach a patient how to do that. The next leg of that stool is behavioral health, and this is pain psychology. So pain is a multi-system, multifaceted experience. Even a simple pain, right? A stubbed toe, your anxiety goes up. You worry about, what's that going to do to when I wear my shoe later today? Imagine living with pain for decades and how that impacts your employment, your mood, your relationships, your experience of the world around you. So at the very least, it's important to recognize that with patients. And sometimes you have to address that professionally as well with some of the strategies I have listed here. The last leg of the stool is addiction medicine, and at least for now, addiction medicine is wed to pain management because we think about a third of patients on regular opioids are also meet criteria for addiction. And this stat too, out of the CDC, is 80% of heroin initiates with prescription opioids. Not necessarily prescribed to you, but taking them from grandma or wherever else. This is another way to look at heroin rising now more recently. And the last kind of slide here in the last area that I think this is where we have a lot of room to grow as a community, as a medical field, is integrative medicine is how it's termed. But this is the umbrella that houses things like acupuncture, massage, regulating breathing, making sure your sleep is good, making sure that you're getting some kind of paced exercise, things more outside the box like aromatherapy, essential oils, healing touch. Now that's not going to work for everyone, but it's definitely worth exploring when you look at the alternatives that we're currently using. So hopefully over the last 25, 30 minutes here, I've described some of these issues in terms of population statistics, the problem. This is why it's on the news all the time. There's people dying every day in this country, almost one a day in our state alone. And then at least started the conversation about where we can go with this, because a lot of this comes from chronic pain, and it's a problem that's not going to get any smaller, right? We're an aging population, and spines aren't getting younger, hips and knees aren't getting younger, so we've got to come up with a way to responsibly, safely, and longitudinally manage some of these things. So I will leave time for questions. I think we have a few minutes. If we need to do other things first, I'll also yield to the team here, but thanks for listening to me. I saw your hand first, but I don't know.
I kind of liken this, as I'm trying to digest this information, it's sad to me. I see it really as a public health concern. It's like smoking or tobacco use became a public health concern, and for years we were telling people if you just quit smoking, this problem, will be healthier and your life will be longer. But until we work to change systems and practices and policies, there wasn't a dramatic increase in the number of people that quit smoking just by saying, you should quit smoking. This is your behavior.
And
is there a similarity? I mean, we can.
It's going to take. It will take massive systemic and expectation shifts, and this is going to be a much harder challenge than smoking because this is something that is a lot of the times hidden, right? You can't have a no opioid zone, right? And the withdrawal is just as bad, if not worse, from smoking. There are alternatives that are unsafe, like heroin. All of these, heroin and morphine, the difference between the chemicals is very, very small. In fact, they use heroin in Europe as a pain medication, and it's called diacetylmorphine. So it's all heroin, but it's available on the street.
You're still going up against really big industries, though.
Huge industries with very powerful influences, and the system is set up right now to fail, to be completely honest, because I am paid on how many patients I see. And I can tell you I would make a lot more money if I just saw the patients, churned them through, gave them their refill, and told them good luck. But that's not what we set up to do. So at TRIA, this is our practice model, what I showed you at the end.
Well, real quick, I know we're kind of
I'll
running
stay
for
a while.
time, but you're willing to stay for a few
Yeah.
minutes? Just feel kind of compelled to add to this heroin piece when you were talking. They are interconnected. In Bloomington, we've seen an uptick in heroin overdoses. But what connects the two is most people won't start illicit drugs at the heroin level. That is just not where marijuana, even cocaine at times, but heroin is usually considered to be a pretty serious junkie type drug. But if you've been addicted to opioids, there's a natural transition because as it becomes difficult to find the prescription drug, that's where people will make the transition to heroin, even though they've not been illegal drug users before. So what happens then is the heroin, they don't know the potency of it. Some of it's coming from Mexico. A large percentage of the heroin in Minnesota comes from Mexico, but it also comes from Afghanistan and Southeast Asia. It's all different potencies. And so people take this and all of a sudden they have this devastating outcome. But real quick, Pete, thanks for coming out today. I think it was a great presentation, very timely in light of everything that's been going on. And as a small token of our appreciation, a Rotary pen. And thanks again for your talk out here today.
Thank you very much.